panelists. But first, my colleague Margaret Montgomery from the WASH unit at WHO will present a little bit the context of WASH for quality of care. And then we have two speakers. We have Dr. Michuki Maina, who is a pediatrician and a public health consultant, and he will present the key finding of a study on access to WASH in Kenyan hospital, and both at the facility level and at the ward level. And then we have Dr. Pauline Kamau, who is a senior pharmacist at the Nyeri County Referral Hospital, who will talk about her experience of this finding and access to WASH in her facility. In total, they will present for half an hour, and then we'll go to the question and answer. Again, please type your question and make sure to tie them to all attendees when you send them so everybody can see them. Okay. Maggie, over to you.
Sure. Thank you, Benedict. And thank you all for joining it, which I know is a very busy and stressful time. So as Benedict said, I'm in the Water, Sanitation, Hygiene, and Health unit at WHO in Geneva, and I'm the focal point for the work in WASH and healthcare facilities. And I'm sure, well, I hope many of you are already aware of the work that WHO and UNICEF are doing on WASH and healthcare facilities. We especially were bolstered last year by a new resolution with the World Health Assembly, which calls on countries to take very specific steps to improve access in healthcare facilities, such as making sure that national standards are in place, investing in training in the health workforce, but also doing work at the actual facility level, not only to improve infrastructure, but to improve how that infrastructure is managed. And it's great that Michuki will give a little more insights in how this is happening in Kenya. With 1 in 4 healthcare facilities in the world lacking basic water and 2 in 5 healthcare facilities having no hand hygiene at points of care, we know there's huge gaps, and this is becoming all the more relevant with the current COVID outbreak, and protecting not only patients, but also the providers in healthcare facilities is critical. So just wanted to mention 3 things about Michuki's work, and my colleague and I, Arbala, had the pleasure of interacting and having a few brainstorms with Michuki over the past few years with this project. First, it's a fantastic example of how they've adapted the existing WHO UNICEF Water and Sanitation for Health Facility Improvement tool. And it's exactly the kind of things that we're hoping hospitals and countries will do. And he'll tell you a little more about that. I think the second thing is just the ability of this innovative way to adapt the tool to make very quick changes. And some of these are very simple changes, and I won't spill all the beans because I'm sure Michuki will tell you, but for us, the great problem of lack of WASH in healthcare facilities is something that's solvable. We know exactly what needs to be done. The resources in many places are there. So it's not something that, we don't know how to fix it. We do. And a lot of it depends on leadership and accountability. And I think that's the third thing I just wanted to emphasize, is the way that Michuki and the team were able to assign accountability at different levels within wards, within facilities, within districts, to particular aspects of the WASH was really powerful in not only helping them to identify the major bottlenecks and the problems, but come up with solutions. So I'll stop there. If anybody has any questions more generally about the global work or how they can get engaged, please reach out to me or type your question in the chat, and I'll hand it back over to Benedict.
Thank you very much for this introduction, Maggie. Michuki, are you ready to start your presentation explaining the key finding of the study?
Yes, perfect. Good afternoon, everybody, and good morning. Thank you for this opportunity. As you heard, my name is Michuki Maina, based in Nairobi, Kenya. So I'll present part of my doctoral work, which has been looking at in Kenyan hospitals. And I think I would want at this point to really acknowledge that this is work that has many people have been involved in this work. Want to acknowledge Professor Mike English and Professor Constance Schulz, who have given a lot of direction and thought into this work as we've gone through it. So to give you some background into this work, it's important to appreciate that water sanitation and hygiene really, and the structure in it, are quite integral in improving infection prevention and control in hospitals for various reasons. There is a lot of evidence out there that really improving WASH can have several benefits, and I've just highlighted some of them. Reduction of hospital-acquired infections. We know that people go to hospital to get better, but unfortunately, depending on the situation, you can actually acquire a hospital-acquired infection. And the problem with those, most of them tend to be drug resistant. So there's the whole issue of antimicrobial resistance. And also, they are quite costly to treat. And so when you look at this holistically, this improving WASH can actually have reductions in all this. But there's also a big area in terms of improving staff morale and also improving quality seeking, quick care seeking within facilities by the people seeking care. So there's quite some body of work that says that people want to show up into cleaner hospitals. They have actually more confidence in the healthcare providers when they go into a clean hospital. That's why we are really taking a bit of time to really improve WASH. As Maggie had pointed out, there's a report that was released last year and talks about maybe a quarter of the facilities that were surveyed in this survey. It's an interesting report. Almost a quarter of them didn't have basic water services. So there are challenges, and most of us, I'm sure, we are familiar with some of these challenges. Now, about 3 years ago, the WHO, in collaboration with UNICEF, put together a fantastic document, the Water Sanitation and Hygiene Facility Improvement Tool, what is commonly referred to as WASH FIT. The development of it was piloted in several countries and in different contexts so that we can just get everything right. For those who are not familiar with it, it covers about 4 domains. That's water, sanitation, and hygiene, and also a domain on organizational management. And each domain has a set of indicators and targets that hospitals or facilities are supposed to achieve, so to get minimum standards for what is called a clean and safe environment. Some of these standards really have been taken from other WHO documents, including the care components of infection prevention and control. And that's why our work was assessing infection prevention and control, but using water sanitation and hygiene, because these two areas, especially in healthcare facilities, are quite connected. So going to just a bit of objectives of what we were up to. The WASH FIT, as it was designed, was really never meant to be a monitoring tool. And that was quite clear from the onset as the WHO team developed it. And so for us, we wanted to ask ourselves, is there a way we can have a survey tool that can be applied to monitor infection prevention and control in hospitals? And if we have this tool, take it to the ground and then evaluate these arrangements in a context like Kenya, where we have a single public health system. And so we really wanted to see how WASH is in public health systems. And so the fact that the original tool was not really meant to be a survey tool or a monitoring tool, that meant that we had to do a bit of modification to it. And so modifying this tool, the original tool was really meant to be a facility level assessment tool, but we acknowledge the fact that most of the public hospitals, especially the larger one, have several inpatient units, and really facility level data may not really be a true reflection of the situation in the wards. And so we really wanted to modify the tool so that we can actually get data from at ward level and also at facility level. The second thing, as Maggie rightfully alluded to, accountability has been a major challenge in our setting. And I'm sure most of us in the quality of care network can attest to that. And so we really wanted to have people being accountable to improve any challenges that would acknowledge in our surveys. And we had to get a new, based on the health system as it exists, to see who would be accountable at what level. And the third part was to try and use a scoring system so that people are able to monitor and see if we are getting better or really getting worse. And that would be make it easy for hospitals to compare performance, for specialties to compare performance, and also to really be able to see feedback to the people who are responsible if things are getting better or worse. So we went out to collect data in about 14 public hospitals. The map there is showing some of the hospitals that we did this work in. And I need to at least say at this point that the selection of these hospitals was actually extremely purposive, because we have, as KEMRI-Wellcome Trust, have had work going on in these facilities, especially in the pediatric units, as to improve quality of care, but we've not done much in the adult and surgical units. And so these 14 facilities are, you can notice there are not too many in the eastern side of the country or the north. So because we already have ongoing work in these facilities. The other thing that was actually useful for us is to have these surveys being done by people who are resident in these facilities. And the whole idea of that was to be able to train the hospital representatives. Those are infection prevention and control leads, public health officers, nursing officers, to be able to conduct surveys independently even after the research project is complete. And so our data collection was really mainly by the people who are resident in these hospitals as a way of capacity building. The third important thing was to try and understand the context a bit better, was to carry out interviews with hospital managers and frontline health workers. So we had about 31 interviews with the healthcare workers in 7 of these 14 hospitals, so that we can get a better understanding of what these survey data are telling us. And going straight to some of the results, when we think about accountability, this was a very iterative process, trying to think out of the 65 indicators that are provided by the WASH FIT, who would take responsibility for what. And so from our Kenyan context, we've thought of 3 major levels of responsibility. That's the highest being at the county or the regional government level. The second was the hospital management. You would agree with me, the hospital director or the medical superintendent has a lot on their plate. And so giving them another 65 indicators to be to look out for would most definitely be quite difficult. And that's why we, after the hospital manager, actually found that there's at a lower committee level, the infection prevention and control committee would come in quite handy to be able to look out and monitor how some of these indicators are performing at hospital level. We also definitely want to acknowledge that the role of the central government in terms of giving policy direction and providing any guidance. And so, but in terms of just the 65 ward indicators, the 3 levels at county, hospital management, and infection prevention committee level were felt as the people who would really take responsibility to improve WASH. And when we think about hospital management, as I said, we are talking about the medical director, the hospital management board, the administrative officer. So it's really not an individual, but we are thinking of the team that is really running the hospital. And also, to make this relevant to other countries and situations, these levels of responsibility can really change depending on the governance structure that is available in different countries. So this was, the regional government was quite specific for contexts like Kenya or Nigeria, which have governors, and so it might just be the central government, hospital managers, and IPC committees in other countries. The other thing that we did was to try and make these data useful for decision making and managers. We tried to get a scoring system so that we can be able to put numbers to what we are seeing. The original WASH FIT tool has 3 levels: we either achieve standard, achieve target, you have not achieved target, and or barely achieves target, or doesn't. So you have 3 levels. And so what we did, out of these 3 levels, we gave you, if you achieve them a standard required, we give you 1. If you barely meet the standard, you get we give you 2 if you've achieved, 1 if you've barely met the standard, and 0 if you've not met the standard. And so out of that, we can be able to compute a score out of 100, assuming if all the indicators were fully, all the criteria were fully met. And so what this chart tries to tell us, the vertical bars up there is the overall hospital performance, looking at the 65 indicators for each hospital. And what you appreciate is that performance was quite varying from almost some hospitals at about 47%, and comparing these 65 indicators in some other facilities at about more than 70%. The horizontal bars on your right side give us the overall score for the specific domain. As I said, we had 4 domains that we were looking at, and the individual cells that are different colors give us the score for each hospital for each domain. And what you can appreciate, we coded them in colors. If you have a percentage aggregate score of less than 40%, the color is red, and 80% is over 80 is green. This is a good visual representation because people can appreciate if we are moving from the red to the green, and also appreciate if things are getting worse. And so this was a way of trying to, at facility level, trying to aggregate performance across the 14 hospitals. The second level, as I said, was putting things at ward level. And so this plot, each of the dots that you can see on this plot represents a ward in a hospital, and the horizontal across all the 14 hospitals, and the 4 domains represented. So what I want to turn your attention to this plot is, for example, what I have highlighted in the red box. This is a sanitation domain in one of the hospitals, hospital number 2. And what you can appreciate is that performance is actually quite varying. Examining the exact same indicators within the facility, different wards have different performance. Some at almost less than 40% compared to others that are doing well at more than 80%. And so this variation within the same hospital, within wards in the same hospital, was quite interesting for us. And so we went out to try and really understand what would be driving such variation within a single hospital. And some of the things that really came out, really this was the data that we picked from our interviews, was the truth is that there are really challenges with the built environment. For example, some hospitals have newer ward units which were built more recently, and so maybe the structure and the infrastructure is much better compared to some older wards within the same facility. But also there's an issue of resource availability and allocation within some of these facilities. And if it's not well allocated, you might find some wards doing much better than others. But what really came out for us was leadership at ward level and also at hospital level. If you have a leader who is extremely passionate about improving WASH and IPC, we would actually be able to see that that ward was actually performing better. They are more vocal at the meetings, and they're able to get things moving even at the meetings. The other insights that we really got is some of these hospitals were actually outsourcing, for example, cleaning services. And the thought is, could this really be a solution to improving our general cleanliness, so that you have a company that is just purely focusing on cleaning these facilities? The other thing that really came out is that from the interviews is that people have very different attitudes towards infection prevention and control and WASH. And some of the things that are coming out is that this is for a certain cadre of people and not for us. And so trying to improve these attitudes personally and at professional level, so that everybody is really on the same page, but also trying to improve training and orientation for all cadres when they're showing up into a hospital to improve WASH. The other thing that also was quite interesting and came out as a highlight is the role of partnerships to improve WASH. There are several development partners within these hospitals who are happy to support various aspects. And so highlighting to some of these partners which areas the facilities would need help, and they're able to put in a bit more resources into that area. That also showed that these are some of the things that would improve WASH. But at the end of the day, I think what stood out is leadership is important. Whether you're outsourcing the services, you really need leaders who are passionate and who are keen to improve infection prevention and control within these facilities. To conclude, just my thoughts is that it's really important to improve WASH. WASH is a key pillar in improving IPC within our hospitals. There are significant differences that exists across and within hospitals in our setting, and enhancing accountability, and in this case leadership, and improving resource allocation would go a long way to improve WASH. And so those are some of the things that came out. Thank you very much. The next, and I would really want to at least acknowledge a couple of groups of people who have really put in a lot of work to make this work a reality, from our funders to the government of Kenya and our colleagues at the WHO. We are really grateful for spending time and giving us your technical support to be able to do this kind of work in our setting. So what I want to do now, I want to hand it over to Pauline Kamau, who is one of infection prevention and control lead at one of the hospitals where we did this work, to be able to give us her reflections and her thoughts around this work that we did. Thank you very much.
Thank you, Mishuki, and Dr. Pauline Camo. Let's have another 10 minutes so people still have time to ask questions. So until 36 past the hour.
Good afternoon and also good morning. Thank you very much for the opportunity to present, to make this presentation. And I'll go straight to it. And following the presentation that we just had, being one of the facilities that participated in this exercise, it's been 2 years on the assessment, and we appreciate a lot the assessment and the results and the feedback that we received. And we've been doing a lot to improve our practice. And as part of the objectives of this presentation, I'm just going to highlight the best practices that we have managed to encounter or to even put in place, and also highlight the challenges that have hindered the optimum delivery of the patient care in the setting of the WASH. If I go straight to the background of the institution, just to put everyone on board, this is the facility's name is Nyeri County Referral, previously known as the Nyeri Provincial General Hospital. It's basically a regional hospital, which is considered to be a level 5, meaning that we have various specialists or specialist clinics, and we also have both the inpatient and outpatient. Started way back in the 1930s, and that's quite a long time ago. We have to admit that the hospital itself has remained the same, with the same infrastructure that has been there over time, due to constraints in resources to even put up additional wards and even the sanitary facilities. In terms of bed space, we have 270 beds and 50 cots available. But we observe that the bed occupancy is usually an average of 130%, meaning that we usually have congestions, we have patients sharing the bed, and that has caused a lot of challenge, because we know the moment patients coming in with different conditions share their space, the issues of infection prevention become a challenge. The issues of the hospital-acquired or healthcare-associated infections are on the rise. Their stay in the hospital is also on the rise. And ultimately, the cost of their treatment goes up. The daily outpatient attendance is quite high also, it's 582, with also an inpatient admission of 116. So you can already see that the hospital, being a regional hospital, serves at 5 counties that are surrounding. Now, the key issues that we would want to highlight as part of our achievements, if we can go to the next, the core issues that we would want to highlight as part of what has helped us to improve our services would be on the leadership and governance structure, and I'll highlight that. accountability. How do we ensure that we have proper channels of making our activities and our work are known? We have the shared responsibility roles that we have as the IPC committee, and then we have the education and capacity building, creating awareness to the other healthcare workers and about the monitoring and evaluation. If I go straight to the leadership and governance structure, we have managed to set or have a formally instituted committee which is multidisciplinary. The members of this committee are drawn from different disciplines. We have everyone on board. We engage at the level of our committee meetings. We have been able to develop terms of reference, which is comprehensive to match the mandate that we have been given as a committee. The members of this committee are also formally appointed, meaning that they appreciate the work that they do in the committee. We also have a dedicated and committed IPC focal person who represents the committee at all levels, both the hospital and also at the county level, to just put across the issues that the IPC members have observed, and also advocate and push for the agenda of the IPC team. We also have a team of link persons from all the departments, and I have to note that especially at the ward level, we have link nurses as our key link persons, so that we work with them closely, especially in the implementation of the programs and activities that we have set out in our action plan. So this whole team actually has been able to put across or even manage to forward the activities and make sure that we stay on course in terms of the action plan, and put together any other inputs that would be drawn from the other members of staff that are not in the committee. Now, we have the next would be the accountability. This committee, being an IPC committee, is actually represents the hospital. So we make monthly progress reports to the management. We review the trends that we have observed. For example, in the case of bed sharing, we have put across several proposals to the hospital in terms of just trying to decongest the hospital, and the reasons as to why we cannot afford to continue encouraging the bed sharing. We also have an elaborate work plan, which we implement on a day-to-day basis, obviously with follow-up and as a team. We do a lot of collaboration with the Medicines and Therapeutics Committee, especially on the areas of antimicrobial resistance. We know that while they might be advocating for the rational use of antibiotics, there is also the need to strengthen the IPC activities, both at the facility and at the ward level. So while they are on the other side advocating for the proper use of antibiotics and all the other drugs, in case of any pathogens that they are isolated in a particular ward, we are able to come in and sensitize the healthcare workers on the need to improve and enhance their IPC practices. At the facility level, we also participate a lot in county forums. There's a particular forum that we participate a lot in, which is the County Antimicrobial Stewardship Interagency Committee. It's drawn from its members are drawn from the Ministry of Health and the Ministry of Agriculture, Fisheries, livestock, and the idea is just to make sure that again the whole issue of multidisciplinary comes in, and as part of their key focus is the enhancement of infection prevention and control, together with issues of surveillance, issues of rational use of antibiotics, the issues of research and development. So we participate a lot, and even at the county level, we give our input as a hospital just to highlight on the areas that we would want them to assist us and even get involved in. Now, the other area is on the shared responsibility. Like I mentioned, the team that heads or that leads the IPC activities is multidisciplinary. So we see a lot of teamwork in the amongst the members in the development of the action plan. Like I said, we have an annual work plan that is currently ongoing. Issues of hand hygiene are highlighted there. Issues of healthcare waste management are highlighted there, and also the issues of surveillance of healthcare associated infections. We are in the course of implementing that work plan, and a few areas that probably will come up as challenges will be highlighted at the end of this presentation. But just to notice that as we implement this action plan, our focus is to prioritize on the activities. We do a situation analysis. We are looking at what is the low-lying fruits. What can we do with the minimal or the limited resources that we have, and get on to it. Things like availing the sanitizers in the clinical areas to enhance hand hygiene. Those ones we are doing. In terms of providing the water and making sure the water is constantly running, we engage the maintenance unit to make sure that the water is running. If it is in the issues of healthcare waste management, we engage the public health colleagues so that they can assist us in ensuring that we safely dispose our waste from the hospital and even within. So the other one is we've developed a chart that highlights on how we will coordinate the issues of hand hygiene. It's called a RASI chart, where we have who is the responsible person, who is accountable for a particular action. If, for example, we notice that a sink is malfunction, who is the responsible person for fixing that sink? Then who are they going to report to? Who will follow up? So we have a very clear outline on who exactly will pick the issues of hand hygiene so that we can enhance the practice and ultimately improve on the compliance rate. Then we are in the process of also developing or customizing the healthcare waste management policy. We realize that there is one at the national level. So we are adopting some of the principles that are there. And the purpose is just to make it simplified for our healthcare workers to ensure that it is easily adopted at the facility level, and subsequently enhance the management of waste, and which we already know that is important to do as we improve the patient care. Now, the other piece that I would want to also point out is on monitoring and surveillance. We do a lot on this on a routine basis. Number one is on the hand hygiene compliance audit. We, at some point late last year, we conducted hand hygiene compliance audit just to check on the compliance of the healthcare workers. This was supported by one of our partners. And as a baseline to just everything that we're doing, we realized that the compliance rate was across the board was actually at around 34%. We hope to achieve an upward trend on improving that compliance rate, and we've set out a target of about 80% by the end of this year. So we are doing bits and bits. What we are doing is that we have quarterly plans. We do trainings. We do the we do the planning, we do the training in one month, and then the other last month we are doing the audit. So this first quarter, actually, we've already done that bit. The audit that we conducted is in the process of being prepared. The report is actually in the process of being prepared. Now, we do weekly commodity audits. We check on the stock status of some of the commodities that will be necessary in terms of improving our hand hygiene, the availability of the sanitizers. Do we have enough soap? Is it available at the clinical areas? Do we have the bin liners that are important for segregation of waste and the appropriate bins and the like? So this is done on a weekly basis, and we do this a lot with the help of our link persons because they are the ones who are on the ground. Then we also do ward infrastructure audits, and this is guided actually by the WHO Ward Infrastructure Survey tool that highlights a lot on the different items and equipment that we would require, especially for improving the hand hygiene. So we have adopted that tool a lot, and we put it into use when we go around to just check on which hand wash basin has a malfunction, which one is requires the attention of the the hospital management maintenance unit, and obviously follow up to ensure that it is fixed. Then we also been doing a bit of the healthcare associated infection surveillance, and we customize the tools, and this is done by individuals in the committee who have an interest in the health in these HAIs, and their role actually is just to check on how well we are avoiding or preventing the HAIs. And a particular one that was done recently is on the surgical site infections. And this one was conducted on elective cases, post-operative. So we managed to observe that while the patients did not contract or get any HAIs, there is also the misuse of antibiotics post-operatively. So we are now advocating, and that is why we are working very closely with the Medicines and Therapeutics Committee to reverse the trends so that they prefer to use the antibiotics before the surgery as opposed to putting the patients on antibiotics after the surgery. So that is something we are working on. It is an in-house tool, but nothing, we hope to get a standardized and a more comprehensive tool to do even the other HAIs. Now, in terms of awareness and training, we've been doing on-job trainings of healthcare workers and also the support staff. We have managed to conduct this. In the recent past, actually in the month of February, we conducted trainings on hand hygiene and healthcare waste management. And from our assessment, we were able to target to get on board about 57% of all the healthcare workers being trained. This is being done on every quarter. Every quarter we do a bit of the training because we cannot pull out all our healthcare workers for training. So we will be doing
I'm
them.
sorry. This is Bene. We will need to wrap up soon because otherwise we will not have an answer to the question that they've been asking you while you presented. Is it possible to wrap up in the next 2 minutes?
Yes, we actually
Thank you.
coming to the end.
Thank you.
Yes. So we now have the materials, the posters available in the clinical areas, and we continuously update our healthcare workers on any emerging issues, just using every other platform that is available to us, online and even offline. Now, some of our challenges have been that the congested wards have been an issue in terms of implementation. Just like I said in the beginning, the bed occupancy is quite high. So ensuring that the staff practice IPC and the patients also practice IPC is not easy. Like I said, also the facility is an old structure. So the sanitary facilities are strained based on even the numbers that we are receiving. The other bit is that the IPC activities are not part of the performance appraisal of any or most of the staff, except the nurses. So most of them do not get any recognition. They do not any action. They do not get any action when it comes to performance or non-performance of IPC practice. Then we obviously lack a healthcare associated infection surveillance system, which is standardized, which would guide us in terms of the direction that we should take in management of these HAIs. Then as part of our recommendations, we would want to, we would hope that we can get a budgetary allocation or some more resources allocated to IPC activities, because as it stands, the IPC activities ride on other activities, so that even in the event we want to fix a hand wash basin, we have to go back to the funds that are there in the hospital, try and squeeze in a bit on what we want to do, and then you get, sometimes there's a lot of delay, and that obviously affects the practice. Then obviously establish a surveillance system that would guide the practice, and continuously just train our healthcare workers, sensitize them on the need to just continuously practice IPC. Yes. So as that is what we've managed to achieve based on the results that we received from the assessment. And obviously there's a lot of need to work with others. There's also the partnership that would be encouraged, the involvement of partners at all levels. I would want to acknowledge that one of our supporting partners, the USAID SID MTALS project, has been on board in just giving the capacity building, some infrastructure support, giving us some commodities. So we appreciate a lot the Ministry of Health and obviously the county government, and even the ones who conducted this assessment. We appreciate and acknowledge the work that you have done, and thank you very, very much.
Thank you so much, both Mishuki and Pauline, to explain a bit the key finding, especially the role of leadership to improve care within existing resources, and then the structure and what to put in place at the world level and what this means. Thank you. We have a few questions for you, for both of you. The first one from Pavaniram from USAID is whether you observed any patterns in which wards were especially challenged on WASH and IPC, for example, surgery or labor and delivery.
Yeah, I'd take that, Pavani. Thank you so much. Actually, what really stood out is the different wards had different performance. So there's some surgical units that were doing particularly well in some hospitals, but in other facilities, it's the neonatal units that were doing well. So there was really no specific pattern in terms of our hypothesis was that we would expect perhaps the neonatal units to be way ahead, but on the ground, at least across the 14 hospitals, things were quite different. Because, for example, in some facilities, the surgical ward is in a very new unit, and so it was really doing extremely well compared to. And some other wards, the leader was extremely passionate, even in the medical unit, to make sure the bins are in place and are not filled. And so, yeah, so it was quite varying across the different units.
Okay, thank you very much. Another one from Indira Narayanan, who is involved in some quality improvement activity with a set of hospitals in Ghana. And she would like to know if you can give a little topic or activity that you have found the most feasible and successful for PDSA cycles. and the impact that they had on infection prevention in your program?
Interesting. Thanks, Indira, for that question. So I think one of the things I didn't highlight is that we had a specific report for each and every facility that we surveyed, and the report was extremely geared to what we highlighted, what were the issues, and it was really up to the facility to take up, as Pauline has rightly explained, to try and understand what are the things that we can work on at minimal costs and be able to improve. So we really don't have a list of indicators or topics or activities that are most feasible and successful, because these were quite different with across the different hospitals. But I agree with you, that would be quite.
What is the compliance rate at the hospital? Now, the tool that was used was a WHO observation tool, which was supposed to just have the assessor check or observe as the healthcare provider was making the or just giving the service. Are they observing the 5 moments of hand hygiene? So without even informing the healthcare workers, they would just observe how they're conducting their service. Are they washing their hands before as they do the procedures, as they touch the surroundings, as they leave the patient, the 5 moments, that is. So that was done, and then an aggregate was done, and the compliance rate was computed, and that was submitted to us as an average.
An interesting area of work to explore moving forward.
Thank you. We have a question from Edwin Sai, who asks you if you could elaborate a little more on how the hygiene compliance audits is done.
That's Pauline.
Sorry, come again?
Somebody want to know if you could explain a bit more how you conducted the hygiene compliance audits.
Okay, thank you very much for that. What we did following a training, an IPC training that was conducted by our partners together with the county government of Nyeri, Department of Health. They decided to follow this up with the hospital, and they picked up a hospital to just check on what is the compliance rate at the hospital. Now, the tool that was used was a WHO observation tool, which was supposed to just have the assessor check or observe as the healthcare provider was making the or just giving the service. Are they observing the 5 moments of hand hygiene? So without even informing the healthcare workers, they would just observe how they're conducting their service. Are they washing their hands before as they do the procedures, as they touch the surroundings, as they leave the patient, the 5 moments, that is. So that was done, and then an aggregate was done, and the compliance rate was computed, and that was submitted to us as an average on the facility performance across the facility, or the facility performance across the facility.
Thank you, Pauline. Another question from Pavani Ram, who would like to know how you have integrated the data from the WASH RPC, from the audits, as well as the issues that you've seen that have been seen and mentioned by various cadres of staff into the quality improvement work and activity either at facility or ward level.
Okay, thank you very much. Following the release of these results, we actually used the data or the information that was given to us as a basis for development of our action plan. So our key focus was to make sure we bridge the gaps that were identified in the assessment. Those were in the area.
Thank you, Pauline. Another question from Pavani Ram, who would like to know how you have integrated the data from the WASH RPC, from the audits, as well as the issues that you've seen that have been seen and mentioned by various cadres of staff into the quality improvement work and activity either at facility or ward level.
Okay, thank you very much. Following the release of these results, we actually used the data or the information that was given to us as a basis for development of our action plan. So our key focus was to make sure we bridge the gaps that were identified in the assessment. Those were in the areas of hand hygiene, the health, the waste management, on the issues of sanitation, the waters of hand hygiene, the health, the waste management, on the issues of sanitation, the water. So we try to incorporate as much as possible in our action plan, both this year and even the previous year, and obviously prioritizing on the activities that we can do with the minimal resources, because like I mentioned, we do not have a particular allocation for IPC. So we ride on other services. So we try to incorporate as much as possible in our action plan, both this year and even the previous year, and obviously prioritizing on the activities that we can do with the minimal resources, because like I mentioned, we do not have a particular allocation for IPC. So we ride on other services to draw funds so that we can conduct our activities. So that is how we have managed to just include the feedback that we received and actually make the improvements that we are observing now.
Thank you very much. Just for heads up, we're going to take 3 more questions for the speakers. So please type them in the chat box if you have still a question to ask them. I have one more still, Pavani, who would like to discuss a bit about the intervention approaches that you have used to motivate more buy-in, commitment, and action from the ward and the facility managers. So how to sustain motivation and engage people.
Okay, thank you very much. I will also want to highlight that we realized that initially we did not. So that is how we have managed to just include the feedback that we received and actually make the improvements that we are observing now.
Thank you very much. Just for heads up, we're going to take 3 more questions for the speakers. So please type them in the chat box if you have still a question to ask them. I have one more still, Pavani, who would like to discuss a bit about the intervention approaches that you have used to motivate more buy-in, commitment, and action from the ward and the facility managers. So how to sustain motivation and engage people.
Okay, thank you very much. I will also want to highlight that we realized that initially we did not have formally appointed members of the committee. So we don't have formally appointed members of the committee. So we realized that if we formally appoint members into a committee, and we have a lot of support from the management, meaning that the management is able to come to our meetings, hear our views, take up some of the challenges that we present to them. The members remain motivated. We have to realize that if we formally appoint members into a committee, and we have a lot of support from the management, meaning that the management is able to come to our meetings, hear our views, take up some of the challenges that we present to them. The members remain motivated. We have to also admit that the focal person who is usually who is usually the person who is on the ground, plays a very key role in making sure that people remain uh, engaged and are interested in these particular practices. So we've used platforms like the WhatsApp, which we have a group. We constantly engage with each other on the issues that are emerging. The person who is on the ground plays a very key role in making sure that people remain uh, engaged and are interested in these particular practices. So we've used platforms like the WhatsApp, which we have a group. We constantly engage with each other on the issues that are emerging. We also are looking forward to engaging using. We also are looking forward to engaging using the Zoom platform to do trainings and sensitization on emerging issues. And as much as possible, try and ensure that the people who are in the committee are acknowledged by the management that they are the key people in their respective departments and the Zoom platform to do trainings and sensitization on emerging issues. And as much as possible, try and ensure that the people who are in the committee are acknowledged by the management that they are the key people in their respective departments as lead in their IPC activities in those departments. So as lead in their IPC activities in those departments. So we are trying to use as many forums as possible just to make sure they remain focused on this.
Thank you. And I have one last question that just popped up from Fatima, on whether you could elaborate on the quality improvement team's role in your work.
Okay, thank you. Well, we are trying to use as many forums as possible just to make sure they remain focused on this.
Thank you. And I have one last question that just popped up from Fatima, on whether you could elaborate on the quality improvement team's role in your work.
Okay, thank you. Well, I may have not mentioned. I may have not mentioned this, but there's also a lot of collaboration with the quality improvement team because we have a committee that is involved in quality improvement now. And as part of their activities is just to enhance IPC practice. A member of our committee, which is the IPC, also sits in the quality improvement piece, but there's also a lot of collaboration with the quality improvement team because we have a committee that is involved in quality improvement now. And as part of their activities is just to enhance IPC practice. A member of our committee, which is the IPC, also sits in the quality improvement team. So we try and link our team. So we try and link our ideas and the activities that we intend to conduct with the ones that are being conducted by the other committee. So there's a lot of activities that come together, but we try and align them so that we do not all clash in terms of doing the same thing, but working together towards achieving our ideas and the activities that we intend to conduct with the ones that are being conducted by the other committee. So there's a lot of activities that come together, but we try and align them so that we do not all clash in terms of doing the same thing, but working together towards achieving the goal that both committees would in there. the goal that both committees would want to achieve. So yes, there's so much involvement in quality.
Okay. Thank you very much. Mitsuki, do you want to contribute to this, or are you done? There's no more question coming your way now.
Yeah, this, as I said, this is for us is extremely preliminary work and is work we are interested in taking forward.
Want to achieve. So yes, there's so much involvement in quality.
Okay. Thank you very much. Mitsuki, do you want to contribute to this, or are you done? There's no more question coming your way now.
Yeah, this, as I said, this is for us is extremely preliminary work and is work we are interested in taking forward, especially just looking at what interventions would be feasible, in our setting, seeing this kind of data that is emerging, and so would be really happy to talk more with the people who are interested in this kind of work moving forward. Thank you.
So we did share in the invitation, and we're going to share it again. The reference document, including the WASH FIT tool that both presenter mentioned. We also will obviously share
in our setting, seeing this kind of data that is emerging, and so would be really happy to talk more with the people who are interested in this kind of work moving forward. Thank you.
So we did share in the invitation, and we're going to share it again. The reference document, including the WASH FIT tool that both presenter mentioned. We also will obviously share the presentation and the recording on this webinar. I just put the link, share the presentation and the recording on this webinar. I just put the link on the qualityofcarenetwork.org website, and this will be there today. If you have any questions, you can also contact Mishuki and Pauline, and you will have the details as well. And if you have more questions that you didn't have answered, please do so. So we're going to close now. I know lots of you have to go. We reached the top of the hour. Thank you very much for your contribution, for your patience to set this up, and for your question today. Thank you very much.
Thank you very much. Bye.
Thank you very much. Bye.
Thank you. Goodbye, everyone. Have a good day.
Thank you. Link on the qualityofcarenetwork.org website, and this will be there today. If you have any questions, you can also contact Mishuki and Pauline, and you will have the details as well. And if you have more questions that you didn't have answered, please do so. So we're going to close now. I know lots of you have to go. We reached the top of the hour. Thank you very much for your contribution, for your patience to set this up, and for your question today. Thank you very much.
Thank you very much. Bye.
Thank you very much. Bye.
Thank you. Goodbye, everyone. Have a good day.
Thank you.
Bye.
Hi, Ben.
Yes,
Still there?
I'm still there. How are you?
Very well, thanks. Eh?
Thank you for that. Well done, both of you. I don't know if Pauline is still here. You still here, Pauline?
Yes, I'm still here.
Okay, fantastic. Thank you so much for your time and for setting this up. And we had a good connection today, so I'm glad it worked well.
All right. Thank you so much. We'll keep in touch.
Yes.
Thank you. There is one question which we didn't answer that somebody said.
Hi, Ben.
Yes,
Still there?
I'm still there. How are you?
Very well, thanks. Eh?
Thank you for that. Well done, both of you. I don't know if Pauline is still here. You still here, Pauline?
Yes, I'm still here.
Okay, fantastic. Thank you so much for your time and for setting this up. And we had a good connection today, so I'm glad it worked well.
All right, thank you so much. We'll keep in touch.
Yes.
Thank you. There is one question which we didn't answer that somebody sent at the very end, which is from Thomas Mugumia. Which technology are currently used in Kenya? But I'm not sure what you meant about technology.
No, we didn't have it.
Because we didn't go into IT at all, so I don't know.
Yeah.
I will send this to you. If you can send me your presentation today, can you share this with me? The one you presented now, no need to change anything at this
I'll do
point.
it right away.
Thank you very much for your time and your
Thank
preparation. And at the very end, which is from Thomas Mugumia, which technology are currently used in Kenya? But I'm not sure what you meant about technology.
No, we didn't have it.
Because we didn't go into IT at all, so I don't know.
Yeah.
I will send this to you. If you can send me your presentation today, can you share this with me? The one you presented now, no need to change anything at this
I'll
point.
do it right away.
Thank you very much for your time and your
Thank-
preparation.
Cheers and best
Thank
wishes.
you.
Sorry I had to interrupt you, Pauline, but I could see that people were sending questions and you will not have the time to answer them.
Well, I thank you. You were keeping me on my toes. I think I didn't check my phone while you said you'll tell me. I didn't quite check the time.
No, I
Sorry
know.
about
It's
that.
difficult to keep time. It's impossible to keep time when you're presenting and you have nobody
I
making
know.
signs at you. So I was trying to get your attention. Thank you very much, both of you. That was really interesting.
Thank you very much.
Okay.
Have a good afternoon.
You too. Bye bye.
Okay, bye. Thank you.
QA chat and event. Yeah, you too. Bye bye.
Okay.